Hi, dear colleagues from Lebanon. My name is Dr. Edgar Davila Garcia. Greetings from Puerto Rico. That's a small island in the Caribbean. As I said before, my name is Edgar Davila Garcia. I am one of the professional affairs consultants for Spectrum International. This webinar is going to be about the Euclid Ortho-k systems. We are the Euclid Ortho-k systems distributors for different parts of the world, Asia, Europe, Middle East, the Caribbean, and some parts of the Americas also, okay? Also, we're going to speak about the Medmont topographer. The first subject, Euclid Ortho-k systems. Who is Euclid? Euclid, as you can see, is a 34-year-old company with a long-standing focus on improving the lives of patients with myopia. It provides more Ortho-k lenses to ECPs, that's eye care providers, annually than any other company in the world. Actually, Euclid is the global leader in Ortho-k lenses with nearly 2 million lenses on eyes around the world. It's a pioneer in receiving government approvals for Ortho-k. The Emerald products, that's our main two scleral, Ortho-k lens, has been approved in the US FDA since 2004. Also, it has received the China FDA approval in 2007. It was the first Ortho-k US lens approved in Japan and Taiwan. Euclid, this company, is the first US-based company to have wholly owned Chinese subsidiary. Why are we worried about myopia control? The thing is, we have been getting a lot of information from the Brian Holden Academy and the Brian Holden Vision Institute. Myopia is more than a refractive condition. The prevalence of myopia has nearly doubled since the 1970s. It is expected to become the leading cause of permanent blindness. Based on historical prevalence data and future projections, there will be about 5 billion people with myopia by 2050, or 50% of the whole world's population. Also, we expect to have almost 1 billion high myopes by 2050. So there are significant implications for planning comprehensive eye care services globally. Remember that if we have a lot of high myopes, we have a high prevalence of myopia all around the world, there are a few things that we can expect from that myopia, and we'll discuss it later on. As you can see on the right side of the slide, we have the reported myopia prevalence in selected countries. USA 42%, Hong Kong 862, Chile 17%, South Africa, Singapore 63, China 47, Iran, a lot of different countries. Actually, the prevalence of myopia has been rising from 2010. It was expected to rise 2050, almost doubling it. Okay. The thing is, while we worry about myopia, this is the reason. High myopia significantly increases the risk of more serious ocular health issues, including a 7.8 times increase in retinal pathology, a 3.3 increase in cataract, a 14.4 times increase in glaucoma. Of course, if we have a condition, in this case myopia, and we start thinking about it as a pathology, not only as a refractive error, we will see that this condition may cause a lot of different serious ocular health issues. Can you imagine an increase in retinal pathology like tears, retinal holes, or retinal detachments? Also an increase in cataracts, also a really increase in glaucoma. If it keeps going that way, our future generations will actually be blind, right? The Brian, we have been getting a lot of information from the Brian Holden Institute and its global scientific meeting in 2015, and they expect that if we reduce the rate of myopia progression by 50%, we can reduce the prevalence of high myopia by up to 90%. So the main goal here, we don't have to reduce by 100% the myopia progression. Our main goal is to actually reduce the myopia progression by 50%, and that will be really nice if we are able to do so. Okay. What are the actual possible methods for proactive myopia management? We have seen for the past decade there have been a lot of different studies and research about myopia management, and we have noticed, and we have right now we do have excellent research and information regarding how orthokeratology lenses could be a possible method for manage myopia. Also, we have multifocal soft lenses. We have also atropine in high, moderate, of low dosages. The potential side effects are glare, photophobia, near vision blur. It is not really available. Sometimes it is easy to get 1%, but to get 0.01, 0.025, or zero point zero 0.05 is difficult to get. Of course, if we use more outdoor time, we should be able to prevent myopia at very early age. But that this doesn't slow the progression. We are trying to actually avoid this change in myopia from the early start. In the case of orthokeratonic contact lenses, of course, it is correction free. We have a clear daytime vision. So the use of orthokeratology contact lenses for myopia management is actually is one of the best methods to actually do that, to actually manage the myopia. And that is our main goal during this webinar. That was our main thing to discuss. In this case, using the platform of Euclid lenses. Okay. Why Ortho-k? Remember that Ortho-k is a device-free daytime correction. It is especially beneficial for school-age children. That means they don't have to use any eyeglasses or contact lenses during the day. It is conveniently wear only overnight. As soon as the patient is ready to go to sleep, he will insert his lenses and then go to sleep. It also provides a home-based parental supervision in cases of children. Of course, if the child will be there sleeping at that time during the sleeping hours, of course the parents will be there and they can assume the supervision for the kids. Minimize adaptation symptoms with no lead awareness. Remember, since the kid is going to be sleeping, there will be no blinking involved. No blinking, it means that the lens will stay there, and it minimizes the adaptation symptoms. Also, it overcomes the contact lens induced dry eye symptoms. Remember, these are gas permeable lenses. They don't dry out the eye with the material. These are gas permeable materials, and we don't have to worry about dry eye symptoms in some patients. Also, we could have predictable outcomes with proper patient selections, and we're going to discuss this later on. What is the proper patient for Ortho-k? And the other thing is that the effects for Ortho-k are reversible if you just discontinue the wear. What that means is, if the patient doesn't like the Ortho-k system by any specific way or any specific reason, the patient will just discontinue the use of the lenses, and the effects are reversible. It will come back to the way it was, as simple as that. No permanent changes in the ocular surface or the cornea. How does Ortho-k work with Euclid MLR specifically? Remember, our lens, we're using our open eye wear reverse geometry gas permeable lens. It gently reshapes the cornea, right? The hydraulic forces induce a reduction of myopia up to 5 diopters of sphere with 1.50 diopters of astigmatism. Results are analyzed through patient symptoms and visual acuity. All we have to do is, after starting the treatment, do topography and verify how this lens is gently molding the cornea, and we'll see the effects on it. Of course, we'll verify the visual acuity and see if it's working properly. Also, with topography, we will see if the alignment of this that the specific lens is okay regarding to the cornea in a specific patient. Okay. Remember, those hydraulic forces, they create positive and negative pressure, actually reshaping the cornea and creating an effect in which the myopia will be decreased. Of course, like I mentioned before, it's reversible, and the patient upon waking up, he can remove his lenses and he should be able to see clearly without any lenses at all. Of course, this takes time, or it usually takes from 1 week to 14 days. But after the whole treatment is done, all the patient has to do is just to sleep with the lenses, wake up, remove them, and he will be able to see clearly for the whole day without any problems. Okay. Remember, up to 5 diopters of sphere and 1.5 of astigmatism. How does the orthocology with Euclid emitter work? You can see another picture here. See how it gently reshapes the cornea, and by reshaping it, we change the size of the shape, and it actually uh, gave us that specific treatment in which we are able to see clearly without glasses or contact lenses. In order to do this, in our platform is very simple. All we need is a few measurements in order to have a nice initial fit success while using these lenses. All we have to do is, number one, perform a refraction. I will say don't use an autokeratometer or autorefractor. Just use the regular retinoscopy for those patients and perform a really nice refraction. I need to emphasize the importance of doing a good refraction. Okay? No over minus, just maximum plus maximum VA, a really good refraction. Try not to use over refraction or over keratometer. Also, the next thing you have to do is acquire manual or simulated K readings. So in this case, you can use you can use your regular keratometer, or you can use your nice autokeratometer in order to obtain those readings. Okay, remember, make sure if you need to take 1, 2, or 3 different measurements in order to get nice information, please do so. Okay, because sometimes if the patient has problems with, for example, dry eyes, or the tears are with debris in that specific case, you can get bad information just by actually getting bad readings or bad manual readings while doing the keratometry. Okay. Also, the third thing that we need, first refraction, then the keratometry or over keratometry or autokeratometry, and then the latest measurement, the last measurement will be the HVID, the horizontal visible diameter. Okay. Why do we need the HVID or the horizontal visible diameter? Because that determines the lens size. Remember, if you change the diameter or the size of the lens, that could change also the lens to cornea relationship, and that could maybe affect the way the lens fits. That's why it is very important to measure the HVID. Okay, it determines the lens size. If you're able to get all these 3 measurements, with those we can decide will be the first lens to actually treat the myopia in that specific patient. Okay. Although topography is not necessarily for the initial lens selection, it is necessary for follow-up visits and treatment analysis. If we go back to the other slide, if you remember the other slide, all we have to do refraction, keratometry or keratometry, and then the HVID. You don't need to do topography in order to select the first lens. We even have some calculators that let you calculate that first lens. But in order to follow up the patient to analyze the specific treatment with that lens, we do need topography. Okay. Remember, the patients will not be wearing the lenses during follow-up visits. Of course, remember in the morning they take them off. Then all you have to do is do topography in order to analyze the shape of that cornea after wearing the Ortho-k lenses. If we're able to analyze that shape of those changes and what's actually happening, we will know if the treatment is effective or not. If it is okay, we're happy. If it is not, we can do the necessary changes in order to adjust the fit or verify the fit or enhance the fit for that specific patient. As you can see on the right hand side, we have the pre-treatment, post-treatment, and then the difference or the comparative map. Uh, and it shows a really nice area, very center, almost perfect. You can see the people over there. You see how the size of the treatment and the changes to that specific cornea. Of course, this is a really almost perfect comparative map change, but that's why we need a topography map in order to be able to analyze if the treatment is adequate or not. We have our Euclid Emerald design. We have two different designs, and they fit most corneal shapes. In order to be able to do so, we have the regular Emerald. It works for patients with apical astigmatism and low elevation difference. And then we also have the Emerald toric Ortho-k lens. It works in patients that have limbus to limbus astigmatism, a high elevation difference. As you can see from these two pictures over here, the first picture on the left, that patient has some astigmatism, but it's what we call apical astigmatism. Astigmatism. It is not from limbus to limbus like on the other side. There's a big difference between those two, and sometimes we do need a toric Ortho-k lens in order to be able to treat the cornea as efficiently as possible and to avoid the centration. Okay, we use our unique fitting algorithms. Whenever you supply your ocular data, we can calculate that with our own calculator, and we can actually give you the initial lens that you need in order to proceed with Ortho-k in any patient. What the characteristic of the Emerald, acute Emerald? The algorithm that we have, you don't have to worry about it. We already have this algorithm created for you. Our lenses, they have a base curve radius, an optical zone size for myopia reduction. We also have a proprietary reverse curve to control the sagittal depth for treatment. That could vary from patient to patient. This reverse base curve connects the base curve to the alignment curves, as you can see over there. In the center, the maximum radius, the reverse curve, then the alignment curves, and then the peripheral curves. Okay. The alignment curves maximize centration. One thing, but that is almost imperative in order to be able to provide an excellent Ortho-k fit is centration. If you do have a nice centration, don't worry. The most of the time you won't have any problems actually providing an Ortho-k treatment. But if you have these centration problems, that will damage everything you're doing, and that's why, as we mentioned before, we have a regular Euclid Emerald lens for corneas that have apical astigmatism, and then the Emerald toric for corneas with limbus to limbus astigmatism. So don't worry, we will have, of course, the solution for any trouble that arises. What is the patient selection for Emerald, for Euclid Emerald? Low to moderate hyperopes, I'm sorry, low to moderate myopes up to -5 diopters, and then people with astigmatism up to 150 with the rule astigmatism, or to 0.75 against the rule. E values from 0.3 to 0.7, Ks from 4000 to 46 diopters, and a corneal diameter greater than 11 millimeters. These are the ideal candidates for Euclid Emerald. If you have patients that they fall outside those parameters, don't worry, you can talk to us locally. The Emerald platform is a platform that you can actually change the parameters, and we can maybe create a special lens for that specific patient. I wouldn't say that we should be able to create lenses for the 100% of your patients, but with the Euclid Emerald, the almost more between 85 and 95% of the patients you should be able to fit without any problems. Okay, this is the Euclid Emerald lens, either a spherical lens or a lens or a toric lens. Remember, these are the regular parameters. We can change these parameters sometimes in order to accommodate people that fall outside these parameters. Also, remember, if we were thinking about doing Ortho-k for myopia control, of course, the size of the eyes of kids. Remember, we do myopia control in kids, maybe for from 7-year-olds and up. Of course, maybe the size of the eye of a 7-year-old kid will be smaller than a regular adult, and we can adjust the diameter for kids. No problems. All you have to do is give us the HPID, and we should be able to provide you with a nice lens for that specific patient. Okay, as long as you provide us with excellent information, like we mentioned before, refraction, keratometry, and HBID, and that information is correct, we should be able to provide you without any problems with a really nice lens for your patient. Okay, that could be either for adult Ortho-k or even for myopia control Ortho-k, mostly in kids, and of course, sometimes the parameters change with those type of patients. Okay. What are the designs or characteristics of the Emerald Toric? About the same of our previous lens. The only thing is that we have a proprietary toric reverse control indicated for the in order to be indicated for the digital depth treatment in those cases. What that means is, of course, we will have, in order to align the difference in height among the two meridians, we will provide a toric reverse curve to control that. And in this case, the lens will settle uh, normally with a good centration. I won't decenter, causing any problems. Remember, if we do have astigmatism, from limbus to limbus, the probability of one meridian being higher than the other is almost 100%. And if that happens, of course, the solution that we have in order to be able to centrate the lens is to provide a toric reverse curve. Okay, this proprietary toric alignment curve maximizes centration. Same thing, if you are able to provide us with excellent information at the very beginning, we should be able to provide you with an excellent solution for your patient. It doesn't matter if the patient has limbus to limbus astigmatism. Of course, this could vary. Remember, we have some limits in terms of the astigmatism. With the regular emerald toric, like we mentioned before, 150, 1.50 diopters with the rule. What is the patient selection for emerald toric? Same as Euclid, but like we mentioned before, with limbus to limbus astigmatism, if they're greater than 30 microns of sagittal height difference in the primary meridians, then you will definitely need a toric lens. And then the question is here, how do I know if I have a limbus to limbus astigmatism? All you have to do is do a topography on that patient, and the topography will let you know if it is an apical astigmatism or limbus to limbus astigmatism. The second question will be, how do I know if there are more than 30 microns of sagittal height difference in primary meridians? The only way to do this is to actually do a topography and maybe measure the cord at 8 millimeters in that specific cornea and see if there are a difference of 30 microns or more. In order to do that, you need to have a nice topographer that will be able to actually measure that height difference between meridians. Okay, and we will discuss that later on when we discuss the Medmont topographer. Okay, another thing, if you have doubts, one of the most uh, common reasons for a lens to be the center is that the patient has astigmatism. So the other thing is that you can actually change. Maybe you can have a lens over there, see how it behaves. If we see that the lens is decentering, probably the most common cause will be astigmatism, and then we can create a toric lens for you. Of course, if you have a topography from the beginning, we can actually design a lens for you and verify the need for a toric lens at the beginning, of course, saving you time, a lot of time, chair time, and money. Okay. Like you mentioned before, we don't need topography at the very beginning, but in order to analyze the management or the treatment of the lenses, we do need a topographer. Okay. So in order to, we invite you, right, to build and differentiate yourself from other practices as a leader in proactive myopia management. You can, with these lenses, you can do regular Ortho-k for adults, and you can also do Ortho-k for kids. There's a big difference there. Ortho-k is not the same as myopia management. There are two different things. You can do myopia management with Ortho-k. Of course, in order to do that, you need a platform which you can actually change the parameters. If you have fixed parameters, sometimes it will be difficult to actually provide myopia management in a lot of different cases. But if you have a platform like the Euclid platform, in which you can change the central optical part, in which you can change the overall diameter of the lens, then you can do myopia management also without any problems. So whenever you're trying to do myopia management in kids, remember that you need a platform that easily adapts to the measurements of each specific patient. If you're using a lens that has only one diameter, if you're using a lens that has only one size of treatment zone or the optical zone, then you won't be able to do a lot of myopia management. But with this platform, you can do both of them without any problems, right? So in order to become Emerald certified, all you have to do is go to the website, getemeraldcertified.com. Just enter there, follow the instructions, and you could be easily in a few minutes be certified and then start actually including Ortho-k as part of your services within your practice. Okay. Of course, you have when you try to recruit patients in order to start practicing Ortho-k, our our tips will be to use easy easy patients at first until you became more proficient on it and you are more and you already have a little bit more experience. If you start with a -5 lens with 150 astigmatism, it will get you a little bit of problem just beginning at the beginning. Just start with easy cases, -2, a -250, -3 spherical. That will be the best for you to actually get experience and get used to the platform. Okay. You can always send the clinical information to us at orderseuclid.com. And of course, we have a nice group of people there to actually help you with any problems that may arise without in a small set of time. Okay. Remember, you're never alone when using Euclid systems. We have consultants, we have customer service team that are here for you at every step of the fitting process. Uh, Even calculating the initial lens. We do have a calculator that will give you the initial lens to order. But if you have any doubts in those first one or two or three cases, you can always contact us for calculating the initial lens. Also, we provide advice on the fitting process. If you have any doubts of what's actually happening, or if you have any doubts or how you should enhance the fit, we're there for you. Of course, if you need to alter the design to improve the result, we also do that for you without any problems. Okay. Remember, risk-free fitting warranty, full cancellation within 30 days, and of course, one of the best things that we have in our Euclid platform is that you don't have to invest money in a trial set. Most of the lenses they can be using our algorithm. You can order them easily using the three uh, measurements that we mentioned before. That's refraction, keratometries, and HPID. That's all we need. Of course, later on, after you start doing the fitting, in order to see how the treatment is going, if it's going well or not, we can use the corneal tomographer. Okay, we're there for you every step of the way. So thanks for tuning in for this Euclid embedded part.